So week 9 is a lot of information this week. It is the musculoskeletal and articular dysfunction, and then your neuromuscular dysfunction. So it's all about muscles and bones, and something,
Yes.
nerves that can also affect it.
Okay. All right. Love you. Wait.
Right, let's mute you. All right. So we're going to be doing like I normally do. We'll do a PowerPoint first, and then we're going to do the Kahoots. Today we don't have a quiz, so that's a great thing. So after class, if there's anybody who has anything you need to talk about, please stop and ask me questions at that point. And I'll stay online for those who would like that. This week is going to be a week full of your reviews. I believe they start Wednesday, Thursday, Friday, Saturday, at all different times. Mine's going to be Thursday at 2 o'clock. So I posted that yesterday, and I also posted a review. Now, it's basically what I called the revised review. I'm going to be sending out another one if I can attach it to your Canvas. It's a more comprehensive one, I would say, more slides, something another professor did to try to help you with what's going to be going on this exam. So she took the time to do it, and one of the classes get it, so all the classes get it. So I'll be sending that too. Either or will work, okay? They both have all the concepts you need within them. So, but sometimes it's nice just to look at something else. Oh yeah, I know that. All right, yes, that means this. And as you're going along, looking at something else, I think it really does help. I know that's the way I learn, but it's not always the way everybody learns. So let's go from here. All right, let's go ahead and let's start with our PowerPoint. Got a lot of good pictures that show a lot of good things in this slideshow. So neuromuscular, and then we have musculoskeletal or articular dysfunction. These pictures here are actually a lot of concepts that we talk about. Cast, right? Long leg, long arm, short arm. And then that little baby up top. I mean, that's when your hips aren't born in the socket where they should. And that's a Pavlik harness that we're going to be going over. Now, there's something wrong with that picture. There should be a t-shirt underneath it. So as they're moving and kicking, they're not rubbing and causing skin irritation. And it's on for 23 hours a day, okay? And then the musculoskeletal. Now, that little picture down there is called Buck's traction. And we use that when we want a bone to be pulled so that those little edges, which are sharp, are not going to be going into the muscles and nerves, creating a lot of pain. And we're going to go into how to care on that too. So great pictures here. Now, one of the things we think about is when we talk about problems with bones, sometimes it's going to make a child immobilized, whether it's for life or for a period of time. Now, if you can imagine being a kid who's active and is up and, normal, and all of a sudden something happens where they're not able to get up and move around, can you imagine how these children feel? Now, there are some kids who are born with congenital defects. Let's just mention osteogenesis imperfecta, brittle bone. I mean, these kids, their bones are very brittle and they crack easily. Sometimes just lifting them up, you can crack bones. So those children are immobile for life. So we got to give them some mobility in some way. We have some degenerative disorders, and that could fall into that. And then what about those infections or injuries? Those things can cause you to be immobile for whatever period of time in order for them to heal. And then that therapy that prolongs the mobilization? Well, just remember that Buck's traction. You can't take the traction off. It is used usually for a fractured femur. So if we get that traction off, guess what? That tension stops. Those bones come dislodged and they start sticking back into the muscles and create a lot of pain. So again, that could be on for a month or so if we don't do surgery. Surgery can decrease it, but it could cause prolonged. Now, what happens when you're laying in bed and you're not moving well? Well, there's lots of stuff. I mean, we could talk about blood clots and we could cause about pulmonary, problems and getting pneumonias and atelectasis, etc. We, skin sores and wounds and ulcers. Now, just because you're a kid doesn't mean you don't get decubitus ulcers or you don't get those red abrased areas. Or what about that foot drop? Well, yes, kids can get that too. So all of the things you think in the adult world, let's go over here and let's look at the children world. Well, you don't use muscles, you're going to have decreased strength and you're going to start getting atrophy. And those muscles, those joints are not going to move the way they should. That's why you put therapies into these children, passive and active range of motions. We've heard of that. And yes, it will be used if the condition allows for it. We know that their bodies, their bones become demineralized. They're not using. We have problems with calcium balances. And then cardiovascular, we are basically starting having that blood flow not moving. Walking squeezes muscles, moving squeezes muscles. That helps all of the blood flow get around all over the body. Well, you're going to have a lot of what we call that venostasis that occurs. And with venostasis causes a problem with, oxygen and nutrition and skin breakdown, dependent edema, etc. All of these things can occur with that. And then with that, there's the blood clots also. So what does kids, and think about any patient who literally was an alert, moving around person, and then we put them on bed rest. We put them in an area where they're just stuck in one place and they have no ability to move around. This can cause a lot of depression, right? Because, visitors can't stay there all the time, even with children, as much as we'd like it. So now we start getting these diminished stimuli. So we need to bring that in, whether it's in children, getting child life in there, those distraction things, and maybe bringing even homework in at this point. They're going to want to see coloring and doing and making things and watching TVs and listening to music and doing puzzles and all of those things in children can help them feel like they've done something, a feeling of being good, like, look how well I colored this. And that will stop that altered perception of self, because now I've produced something that really was good. I'm literally showing you what a great kid I am. So it does help those things. As I said, it becomes to the point where you're depressed because you're frustrated, you're helpless. Then you get anxious because, when is, somebody coming to see me? Or, oh, did I miss lunch? Did nobody bring it? You know how sometimes lunch trays get sitting there and somebody forgets to bring them in. And now it's an hour later. Well, these people who are stuck in bed, especially kids, they know I'm supposed to get lunch by now. It's not here. Did I do something wrong? Because that's what a kid will think. And at that point, they're going to start getting angry. And now they're going to start getting either aggressive or they're going to, regress into being, incontinent. And the younger kids, wanting a bottle instead of a cup. All of these things are all part of just not being able to move around. So as nurses, what are we going to do? We're going to stimulate them somehow. Or we're going to say, hey, let's get child life in here. Or let's try maybe physical therapy, just going an exercising routine. Kids like that stuff. Maybe not the older people, but kids do like that. They want somebody to talk to. Now, what about the family at home? You got a family at home, you've got a kid, in a hospital, and these children, everybody needs attention of the parents. So number one, the parents are, feeling bad kids at home and the child in the hospital. So how do I split myself up like that? So the family needs support about this. Now, what if this kid now then is able to go home and continue the care at home? Now you've got a child sick at home who requires a lot of care. Now we need to make sure they got everything they need. Do they have somebody coming to take care of them? Is there a nurse? Do they have the equipment? Do they have the medications? Does the family know how to take care of all these things? So really, it's a big deal for these families and the nurses to arrange all of these sort of things. Now, many of the hospital floors are divided into like sections, like the neuro floor, the GI floor, the lung floor, there's something like the cardiac unit, newborn unit. Well, a lot of them, in fact, all of them that I know of at the hospital where I came from, all have parent groups, and they are invaluable to these parents. These parents share each other's frustrations, and actually they share each other's, like, this is what I did for this, and this worked. So it took me a week to figure it out, but now you've shared it to another parent, and now they know it already. So parent groups are amazing. And then sometimes either the child or even the parent does need individual counseling because they feel overwhelmed, or the child is they just don't understand why they can't get up and move yet. Excuse me. So traumatic injuries, most common thing that happens to kids. It is a soft tissue, muscles, ligaments, tendons, sprains, strains, all of these things that can happen with children. It could be just getting up, going out and play, or it could be in some sort of sports. Now, a contusion is a bruise, and on the outside, it really doesn't look like a lot. Now, remember, those bruises are showing you the outward sign of blood vessels that have ruptured. Well, what swelling has gone on inside that muscle? Has it impeded the neurovascular circulation? So always, just don't say, oh, it's just a bruise. Yes, it hurts, it's tender, it's, elevated. Yeah, no. Check the neurovascular signs distally because it could impede upon circulation, right? Making sure they can wiggle it and they can feel it, et cetera, et cetera. Sometimes these contusions are due to crushing injuries. Again, we still don't know what's inside. Again, making sure that we're checking it, making sure blood flow is going where it should be. And it does. It causes pain, it causes swelling. And sometimes these big bruises are so severe that, now we can't walk the way we should. Maybe we need crutches or something to help them. Now, dislocation is something that happens. Actually, probably the most dislocated thing I've seen is what we call nursemaid elbows. Every little 2 to 3-year-old kid, you're swinging them by the arms, and all of a sudden their arm clicks, and now they've got this arm hanging by their side. What happens is their tendons and ligaments are so soft that they twitch, they get out of joint, and they stretch, and it actually hurts. Now, these kids will have that arm hanging down to the side. I've gotten used to looking at them, knowing what's going on, and I usually go get myself a practitioner or a PA, something. I said, kid's nursemaid, could you quick come get it into its place for him? Because they didn't allow me to. But it's just turning it and getting it in place, putting a sling on it, and now let that elbow rest, because it literally just dislocated on you. Very common. So in these 2 to 3-year-old kids, we wouldn't be swinging them by their arms anymore, right? Because it's going to happen again. That's what they'll tell you. Now, you don't think about Down's children and being as flexible as they are. A Down's child can put both feet behind their heads, but doing that, and some of them do it because they get a response from it, they could pop their hip joints out of their pelvis and cause hip dislocations. Now, hip dislocations, you're going to worry about the lack of blood flow, and it could be a very dangerous dislocation. So we should never ask Down's child to put their feet behind their legs because it's amazing how flexible they are. Sprains. I can't even tell you how many sprains I had growing up. I was always in sports. I had 6 brothers, so I was always in every sport they had. And I actually was pretty good growing up and even through college. And I can't tell you how many sprains I just, went to spike a ball, volleyball came down, and there it did. The whole side, you could hear it ripping. And it was so much pain. You just, oh my goodness, not another one. Well, what happens is the ligaments are stretched. The person can hear it because I remember I used to hear it. And immediately it starts to swell. You've ripped some of the capillaries and some blood vessels. So now you have blood going in there and it is painful. Another thing that could be strain, and this is just doing something over and over again, and it literally causes pain also, but it's not as severe as a sprain, although we treat it very similarly. So how do we treat it? Well, number one, I would like to say it should be price. Number one, protect them first. Maybe wear tape on the ankles, which the male coach used to have to tape me up before every game because I was going to sprain myself somewhere and they wanted me to play. Now that would be that protect. But if it happens, number one, rest. I got to the point where something like that would happen. I'd lay on my back and put my foot straight up in the air. And the coach would be coming over with an ice pack. They knew what was going on. Then they would take and wrap it up in an ace bandage and keep it elevated. Now, they do have little splints and whatnot for sprains today. You know what they do today, like they didn't do years ago? On a very bad sprain, in order to keep it immobile, they now are actually putting cast on for like a shorter period of time. And they're seeing that works. It used to be just an ace bandage or just a little sort of splint. But doing that, what have you done? As I said, it swells instantly, which is part of the pain. So keep it elevated. What are you going to do? You're going to be checking to make sure that there's still neurovascular signs if it's on the ankle, on the toes, right? Part of nursing care. Now, fractures. Most common is the wrist. What do you do when you fall down? You put your hands out, right? Kid comes down quick, and it could be one wrist that could be broken, whether it's going to be the radial, the ulnar, or both. And many times it is both when they come down there. Most common bone broke by children. Now, if you see an infant with a broken bone, it's not normal. It's very hard to fracture an infant's bones. They're actually very soft and more pliable. They become more ossified and more able to crack as you get older. In fact, healing a fracture on an infant could be 2 weeks, where it might take 4 weeks for an older kid and 3 months for us older people, okay? So if you see an infant that has a fractured bone, it needs to be looked at very carefully because our job as nurses is to protect the children. And if we suspect, we need to investigate it because many a times your suspicions are usually correct, or at least tell somebody about it, okay? You're not, getting anybody in trouble. You're protecting a child. And if you protect one child, that's all that matters because children are so precious. There are many different sort of fractures. The simple one is what we think of. Broken bone, put a cast on. It doesn't come through the skin. Now, the one that's the most complicated to take care of is the open or compound. That bone comes through the skin. And once it comes through the skin, it's been infected because there's always staph on your skin. That's just skin, staph, normal stuff. This requires IV antibiotics. That's one of the more complicated things. Now, we do have what we call a complicated one. This could be fractured ribs that could puncture a lung, or the fragments there could maybe the liver. Be careful of those things. And common unit is there's all these little pieces in there, and all those little pieces of tissue create a lot of angry muscles and nerves because they're little sharp little things. Usually those require an open reduction to clean it out and put screws on it, and of course then a cast. Now in children are growing, right? That's the one difference between adults and children. They're always growing. Well, where they grow is in an area in the bones called the epiphyseal plate. And you can see by those pictures down there, it's right at the end of the bone. And this is where the bone grows. So if you can imagine having a broken bone there that wasn't fixed correctly or not at all, what would happen? You might have a shorter arm, a shorter leg, or a crooked arm or a crooked leg. These things need very careful, meticulous alignment so that the bone growth continues and that it still keeps it straight the way it should be. We do surgery on these called an open reduction internal fixation. They'll line it up, they'll put plate screws on it, and these things will hold it into place so that the bones will grow the way they should. Now, remember I said bone healing is different. So little infants, I think one of the things we think of with infants and getting cast on are those club feet, which we're going to talk about. Or it could be that, problems with the hips that need a cast on it. And they usually don't need it on very long. Now, especially those children with club feet. Remember, they're growing extremely quick as an infant. It's like 1 inch every month for the first 6 months is what actually they grow for. And that's a lot of height. So in 2 to 3 weeks, you put a cast on, you can take it off. And if you don't take it off, you better be putting another one on because that bone has already grown. That leg has already grown, okay? Now, the younger kids, it's horrible. The first day of summer vacation, they go out and they break their leg, they break their arm, and they're supposed to go to swim camp in a month, right? And you're like, oh my goodness, now they can't go. Well, maybe they can, because in 1 month, that leg, that arm could be healed and they could go to camp, for that swimming. So it's great that they heal quick. The older you get, the longer it takes to heal because the bone is more ossified. Now, you get a kid come in complaining, let's go right to the wrist. The wrist is swollen and it's tender and it's really hard to move the fingers because of the pain. What do we do? Well, we're going to do an x-ray and we're going to see if it's fractured or anything. With children, I like to show them the x-ray so that they understand what's going on. Don't suspect that they know that there's a crack there. They don't get that, but a picture, they really understand. And then they'll help you as a parent take care of that child. Now, we're going to do a history. Now, this is the tricky part again, because remember, abuse can be fractured bones, but kids are normal and get fractured bones just because they're kids. So, but you want to protect the child. So try to get the kid alone and find out if the parent story is the same, okay? I've actually haven't heard problems like that, when I've seen child abuse. I never found one, although let me tell you, I've found child abuse a couple times. Now, when you have a kid who has, the leg that they can't walk on, you always suspect that is a fracture. Get them a wheelchair so they don't have to walk because it does hurt. So what is our goal? We want to put that bone where it should be, immobilize it so that we can have full function and we can prevent deformities. I think we've already described that. All right, you put a cast on. And that's not all. That's not all what we do now. Yes, we've got it in alignment. Yes, we know it's a fracture where it's at. We know what we have to do. But we need to make sure that that cast does not impede circulation. And yeah, that is a really, the worst end of story is that black arm. But that's just to show you, It can get that bad if we're not checking it. So what are we checking for? It's all the sixes. 6 P's, at least 6. Pain, all right? The pain is getting worse and it's intolerable. It should actually be decreasing in a cast. The fingers, the capillary refill, now you're getting, or the toes, is getting pale. That means no blood supply, right? Well, then that pulselessness, if we can feel a pulse, we're not going to feel it, or it's going to be very faint. Paresthesia, or now we're getting numb in the fingers or the toes, and now we can't move it, and it feels swollen, and it feels a lot of pressure. If a child sees any of this, the parent needs to get this kid back to the ER or to the orthopedic doctor as soon as possible. You know, most of the time, casts are put on in the emergency room. I have heard, at least 1,000 times. Yes, we called up the orthopedic doctor and I can't get an appointment till a month from now. And I'm like, yes, I know. That's about the most common. But most hospitals, especially pediatric hospitals, have pediatric orthopedic techs. And they are trained specifically for children to put on casts. So we can put on casts, we can change the casts. And the best thing about children's hospital instead of adult hospitals, most children's hospitals have pretty colored casts. I'm like, so can you imagine now my distraction? So what color cast do you want? You want yellow? Do you like light pink? Do you like dark pink? Light blue, dark blue? Do you like army, rainbow print, red, blue, green? And they're like, oh my God, I don't know. I said, how about 2 colors? Well, you know, down here in Miami Heat, especially during basketball season, that's black and red. Would you like a 2-color cast? You know something? Just figuring out a color on the cast takes that mind away from, I'm getting cast on, and they do manipulation to get that bone straight, right? And they come out and they go, wow, look at that. Oh, I like the color cast. Pretty cool. So the techniques, I mean, this little girl looks like she has watermelon, right? Orange and pink, but look at her little doll. We put it on her doll too. So again, now we've distracted her from what we've done. And it does help a lot of things. Now, how to take care of casts. I mean, you've had a discussion question, talks about casts, talks about putting a cool air of a hair dryer. That can help. Don't stick anything down in there because you can scratch the skin and cause an infection in there. You know, casts should never get wet. I have a story, this one little kid, I mean, the mother wanted to bop him over the head. He came in 3 times. The first time, he got his cast on. And he did really well, went home. We taught him about keeping it dry. We gave him a bag for bathing. We showed him how to use it, et cetera, how to take care of it, wiggle the fingers, put it on a toe, take Tylenol for pain. We did everything. Well, the next day he comes in, and what happened is he went home, forgot he had a cast, and put his bathing suit on and jumped in the pool. Went, oops, and there it was, a wet cast. And actually, you cannot live with a wet cast because it can grow bacteria and fungus and all that stuff underneath it. So it has to be changed. This kid did it 2 times. So the 3rd time he came in, I told the child, I said, okay, that's enough, no more, because you have to go through the same process of coming into the ER, signing in, waiting for your turn to go to the orthopedic tech to get it changed. You know, this is a couple hours of your day. So I never saw him after the 3rd cast. Actually, I saw him come in one of his orthopedic visits because that was done through the ER in an area. But casts, don't get them wet. That's the bottom line. Now, traction can be skin or it can also be skeletal traction. Well, skin means there's no pins to hold, you know, through the bone to hold it. That picture on the bottom is that Buck's traction again. And what it does, it aligns the bone and prevents muscle spasms and pains, okay? And it can help that child be with no pain until the point where he gets his surgery. I had one little boy come in with a fractured femur, big swollen thigh. And I mean, the kid was crying. It hurt so bad. There was no amount of pain medicine actually that would help him. So we got a regular bed down to the ER. We put the traction on it, put him on it. And by the time he went upstairs, the kid was smiling, the pain had decreased. So Buck's traction works really well. It is weights that go over and it pulled it and stopped that pain. So why do we use these things? Well, you want to leave those muscles to relax so that they're not in spasm. Pain is the big thing. It puts the bones together and it immobilizes it and prevents deformities because children's bones heal pretty quickly, okay? I think the big one is that reducing those muscle spasms. Now that picture on the bottom left is like a halo type of traction on the right. And on the left one is just the pins that go over to hold the neck straight. You know, you would have like a cervical bone injury to hold it straight. And I've seen them all used for many different reasons. So there's all different types of traction. You know, you have Bryant's traction, you know, those legs up in the air, that could be used for the hips instead of the Pavlik, like I showed you before, depending what works the best for the child. You know, Buck's traction is just the straight. Russell's puts like a little extra tension on it, a different way. You know, it all depends on what the physician wants. They both work well. You know, and Gardner, well, those were the tongues I was talking about for that cervical traction. So distraction of a fracture is used. Sometimes we do it when you're born and you have a longer arm or a longer leg and a shorter one, and you don't want them to be limping. Let's say it's a leg, and the leg, the lower leg, the tibia and the fibula were shorter than the other side. So what they do is, you see that metal device on the outside of that little girl's leg? They go into surgery and they break the bones. They separate them and stick pins through it to hold it. And that separation area, it starts to grow bones in between. So by distraction, by an external fixation device, they can make the leg the same size as the other. So this kid will always, they won't limp. They'll have the same length on each side, which, you know, in girls, they want to wear their high heels and be cute when they're older, right? Well, now their legs are right, they'll be able to do those things. Now, amputation could be congenital or it could be, you know, ran over by a car, right? We've talked about motor vehicle and run over. Well, it could crack a leg to the point where you can't, you know, fix it, and they might have to do amputation. I had a friend whose daughter had a missing fibula at birth. So only had one bone in the lower leg. And at the time of her birth and in the process of medical knowledge, there was nothing we could do. So she had to have a below the knee amputation. Well, the day I met her, she came over to my house and was a really good friend. And I, you know, the kids, I'm like, here, go play. They're going up and downstairs, you know, and I hear laughing and giggling. I'm like, okay, they're getting along all right. Well, the next thing I know, this kid is coming down the stairs with her prosthesis, her leg in one hand, chasing my kids around the house, trying to bop them over the head. She didn't care she was missing a leg. She was extremely mobile. And I thought it was amazing to see how well adjusted this child was by having a prosthesis. She did really, really well. So that's being born with it, that they had to do that amputation really right after birth, you know, within the first year. Again, if it is something that happens later on in life, just like adults, phantom pain, oh yes, they'll have it. They've got to make sure that the stump is made in a way that they can fit a prosthesis on it. So again, managing the pain and getting that stump right, and then the physical therapy after it and all of that to make sure that they can walk and take care of themselves. Now, kids love to be active. They are extremely competitive. I know my grandson wants to win, 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 win. In fact, what was exciting, on Saturday, I got to go to my little Christian. He's just 6. He's been taking soccer in aftercare at school. It was an extra thing. This company came in 2 days a week, and I watched him play his first game of soccer. And watching these little 6 and 7-year-old kids run around the field, I thought was the cutest thing I've ever seen. And this one girl on the other team got 2 goals. Oh my goodness, could kick around. And some of the things I saw, these kids were acting like they were adults who played soccer. Now remember, with any sports injury, kids like to get up, go. They don't like to stretch. They just want to start doing what they want now. They are very competitive, so they can be rough and pushing around, and injuries can happen. So making sure that they have proper equipment, that they did have shin guards and the proper shoes. And remember, as some of the things like football, make sure they have a helmet, bicycles or helmets. Making sure they have the proper equipment will decrease the amount of injuries, because they'll have injuries. They're going to sprain their legs, their knees, they are going to be hit, and they're going to get bruised, et cetera, et cetera. Now, you have some children who are very competitive, and they want to be the best that they can be. And you're going to see them training longer, harder, and younger in life. You see this a lot with the gymnastics, right? You hear about these young girls start up very early in life, and they're doing it before school and after school. I mean, that's where you start to see these overuse syndromes, because they're doing these same things repeatedly over and over and over again. And you do see these overuse injuries. Is what we call little micro traumas, right? And then, of course, you'll see, like the kid who likes to run, you might see like those stress fractures. Very common to have. I mean, it's something that needs to be looked for. Okay, DDH, or developmental dysplasia of the hip. Congenital hip dysplasia is what I've always called it as, but of course, they always have new names for something. In girls more than it is boys. And if you look at it, it's from a hip that's normal, and then the one that's not, the most dislocation is sort of sitting on top of the hip. And we got to get that back into the hip, okay? So how do we do that? Well, at birth, we take our child. Within the first 2 weeks, we send them to the pediatrician's office, and they're going to do their examinations there, okay? What's the first thing they do almost all the time? They put the knees up and down and back and forth, and they're listening for that click that's going to go on there. They're also going to turn them on their bellies and look at their gluteal folds. Their skin folds. Is one higher than the other? Because remember, one hip is up top. Oh, also, if the hip's up top, didn't that leg just start to look a little shorter? Yes. So you see that hip is the joint, you're going to feel a difference. You have a short leg on the affected side. You're also going to see those folds, one's higher than the other. Now, positive Ortolani, positive Barlow's, you're going to be hearing those clicks going on there. So how do we treat this? Well, remember, these bones on children, on casts, can heal in 2 to 3 weeks, right? So we need to immobilize it in some way that it's going to be forced to go back into that hip socket. So a Pavlik harness is to have abduction of the hip. That's the key word, abduction, all right? And what that does, it helps it put it back into joint. And usually we'll put this Pavlik harness on. You see how this child has the little t-shirt underneath because it's 23 hours a day, which means you take it off to bathe him and then you put it right back on, okay? And you keep that hips abducted so that we can get it properly. Now, if it doesn't get back to where it should be in about 6 months, they'll decide to put on that spica cast, okay? Which is going to try to keep it really immobile with a cast. These children are going to be in a crib in the bed and they can't walk. And these children, will be with a cast on. One of my best girlfriend's son had to use the spica cast, and that white cast, I mean, these kids still have stools and they still urinate. She had to keep that cast clean. She literally would take a toothbrush to keep that cast clean. In fact, the nurses at the hospital where she used to bring him for checkups said, "This is the cleanest cast I've ever seen." And she goes, "Well, I use a toothbrush to keep it clean. I don't want stool there. It smells, and poor kid shouldn't be laying in it." And she was always commended on it, but she was always a clean freak. So I was glad to see that. Kid is perfectly fine today. Now, if the kid still, after 2 years old, it's not going back. Now, remember, those tendons now are stiff and tight. What they have to do is what we call a tenotomy or an osteotomy. We have to sort of make a hole, open it up so it stretches so we can get that ball of that hip socket back to where it should be, okay? Another thing with these children here is, remember, they need to be followed up and they need to keep those hips loose. So they'll probably be placed on some sort of exercise. Okay, I mentioned sort of club foot. Now, there's all different types. You do not need to know the names of them, okay? There's a bunch: Vargas, Valgus, Equinus, Calcaneus. It's just in, out, all different shapes of the feet, okay? It just means the feet and ankles aren't the way it should be. So how do we take care of this? Well, we need to get those ankles in a position where the child can walk. So what we do is serial casting. So if you look at that picture down below, we put casts on, and these are changed every week. Well, think about how quick kids grow, right? So every week they go back in and change the cast. These kids grow and they need to keep correcting it so that those ankles and those feet get to where they possibly should. Again, we need to be checking those little toes for neuromuscular signs. And, of course, we need to keep that upper body strength and moving. I mean, these kids are usually young. So again, we're just keeping, them reaching for things and reflex and voluntary palmar grasp and rattles and etc. The one thing I didn't say about club feet. Now, one of the things about club feet, as these children are getting older, they need to be followed up because sometimes you might have a shorter feet or something. Sometimes they need corrective shoes for the first time that they're getting shoes. It's like you can't go to Walmart and buy shoes. They need good, solid shoes on their feet. All right, I mentioned it quickly. It's called osteogenesis imperfecta, and basically it's brittle bone disease. Can you see that little child? You can see how many broken bones they have. And they're not going to cast them. They're not going to do surgery on them because their bones are so brittle. So has to do with, they're not sure what all about it, but these bones, I've seen one kid who actually was in the newborn ICU, and because of many different things, he was in with us for almost a whole year in the newborn intensive care unit. And this is a child that if you wanted to pick him up, we would put him on a baby blanket And one nurse would get one side, one would get the other, and we'd pick them up to change the sheets underneath, and then hand her the butt and lift them and change that blanket. Changing his diaper, very careful. This is a kid you had to be so gentle with because you could hear it crack when they cracked, okay? Can you imagine? You pick up by the chest, you could squeeze the rib cage. That could happen. So how do we take care of this? Well, number one, our goal is to have this child at least be able to be in a position to sit in a wheelchair so they have some mobility. You don't want this kid just to be bedridden. That's a huge thing with them, okay? So supportive care, we might give calcium, IV biphosphonate, good healthy diet, but it's, most of the time, there's really not a lot. There's no cure for this. Just trying to keep that body in a position that they can be movable. Now, leg calf purse disease. It's an aseptic necrosis of the femoral head. That means there's not an infection, but for some reason, the head of the femur is dying. And what you see is this is going to be a child, usually white males, ages 4 to 8, mostly one side, but can be both. And you will see a child start limping and start having pain for no reason. Could be the kid who never plays sports, didn't fall down, there's no bruising, nothing. And it's worse in the morning, and it's also worse when they have been sitting a while and getting up. Almost sounds like rheumatoid arthritis, right? That stiffness, that pain that occurs, but it's leg calf purse disease. So how do we diagnose it? Well, number one, it's that history, that assessment, and then, of course, doing an x-ray. And you'll see like a fuzzy outline of the femoral head, which is showing you this is becoming necrotic there. You can sort of see the fuzz on those things there, especially on the one on the left. It's really evident that's where the necrosis is occurring. So our goal is we need to save that head of that femur, okay? Absolutely need to save it. So how do we do it? Well, it's bed rest, no weight bearing, and it's NSAID. And sometimes these children are placed on Buck's traction. It pulls it, keeps it straight, and keeps it from moving, right? That's another time that Buck's traction might be used. So these children will be staying at home. These kids will be doing homeschool. Remember, diet, so important. Well, when you think of muscle bone, you think of high in protein, right? You want good vitamin D because D works with that also. So diet with these children is also important. Now, there's 3 different spinal things that are curvatures in some manner or the other. Kyphosis is the thoracic spine up top, or some people call it humpback. You see it in older people, they're just leaned over and their back sticks out. Well, that is called kyphosis. You can see this in young children. It is because of maybe tuberculosis, could be that osteodystrophy, something that's gone on, kidney disease, right? You'll see osteodystrophy, or it could be a fracture that occurred that's created that posture. Lordosis is that bottom spine. So you're sort of leaning backwards type. The rest of the spine is okay, but the bottom lumbar spine is curved inwards. A lot of times this has to do with that congenital dislocated hip, or it could be in obese children, because obese children could have like a big abdomen causing their posture to be different, and it causes them to get that little angular in the low back. Scoliosis, this is the one that's tested by your NCLEX, HESI. This is the one they always like to pick on. And scoliosis, S-shaped curvature of the spine. So scoliosis S, S-shaped. And you're going to see it, curve. You'll bend over, you can see it. You'll have one shoulder higher than the other. And this can happen from birth, or it's something that can develop through childhood. Now, we're not always sure, but we start to really see it during that pre-adolescent growth spurt. Remember, they gain, 40% of their height during these 2 years. So it's quite a lot of growth that goes on, okay? So pre-adolescent growth spurt, how do we treat an S-shaped spine? Well, let's just look at what happens with that S-shaped spine. If that upper curve is very pronounced, okay, they say greater than 40. That's, that number you'll see 40, 45, the number is pretty high. If it's shaped too much, what's happened is one of those lungs, the space for it to be big is decreased. It can't expand because that S shape has pushed it to the side. So you're starting to impede upon your respiratory system. So if it's less than 40 degrees, they need to do something to try to straighten it, to give the lungs the area to breathe the way they should. And what they do is put a brace on them, this little white plastic, or they've got all different colors depending on where you go and who's making it. But I've seen all different types of colors, rainbows, and yeah, I've seen the leopard, and of course I've seen the white ones too. Now, just like the Pavlik harness that we use for hip dislocation in infants, this is 23 hours a day, and it's like a plastic, so it sweats. So you take it off 20, for 1 hour, you bathe, you wash out the inside of this brace, put another t-shirt, something cotton underneath, and then we put it back on. Well, that's not all we do. We also have exercise. So these children go to physical therapy. They're taught these back strengthening exercises to try to strengthen that. My daughter's best friend had scoliosis, and I watched her go from being really crooked to pretty straight. So, and without surgery, and she had, one of these braces that she did have to use. Now, what if it's more than that? Let's say we're at 55%. Now that's a lot. You're really impeding upon your lungs. Surgery must be done. And what they do is what we call Harrington or Luque rods. And these children on the spine, they attach this rod to try, now they can't get it perfectly straight, but get it as straight as it possibly can be. These children are actually placed on their abdomens post-operatively because the incision's on the back. So these kids are log rolled after surgery, and the kids do okay, but it's a long recovery. All right, an infection of the bone, osteomyelitis. I've seen them in fingers and toes quite a bit. Kids just like me like to walk around with no shoes on, and they be outside and they step on something and they get a little scratch and then gets an infection in the skin and it goes right into the bones. Well, once it gets into the bones and it starts to really evolve there, it's going to cause swelling, redness, pain, and then the body's going to start running a fever in response to this infection. And of course, your white blood cell counts go extremely high. So how do we diagnose these things? Well, number one, we're going to do a CBC. Let's look at the white counts. Let's look at the leukocytes. How high are they? I've seen them up to 40,000. I mean, it's a heck of an infection that they can get. I mean, normal shouldn't be more than about 12. So that's quite a bit, that high. Also, we're going to do an X-ray and we're going to see again that fuzziness. May or may not, though, depending on how much and where it's at. And then they'll do some bone scans. How do we treat osteomyelitis? Well, it's an infection. So these children are going to be on really, really vigorous therapy. IV antibiotics for at least 3 to 4 weeks and maybe months. These children are usually have a peripherally inserted central catheter or a PICC line. And these children and parents are taught, or they have nurses coming in giving these medication. Now, this is usually a staph infection. So these children are placed on an aminoglucoside like vancomycin. It's usually the drug of choice. Remember, vancomycin is extremely nephrotoxic and also ototoxic, can affect your hearing. So these children need to be closely monitored with their blood work, making sure their BUN and creatinine and kidney function are okay. Very, very important. And drink plenty of fluids during this time. Because of all this infection, they need to keep that limb immobile. Of course, we're going to address the pain, and then of course, nutrition again. So, well, what did I tell you about leg calf births? Well, again, it's going to be protein. We need protein is good for these children. It's good for muscles and bones, and of course, your vitamin Ds. And again, these children are going to be, again, alone, maybe home from school for a month, depending where it's at. So again, those psychosocial needs are important. I mean, thank God for Zoom today and FaceTime on our phones. I mean, this wasn't here 10 years ago, right? I mean, can you imagine what did the kids do back then? They talked on the phone, or we took pictures and sent them to each other. Ewing sarcoma is basically a bone tumor, and it's in the femur, tibia, ulnar, humerus, vertebrae, pelvis, scapula, ribs. Now, I've got a picture of a scapula. That bottom left is the right one. And look at the jaw on that left one. And the bottom right one, you see the jaws there. And again, they've got to get those out. They'll do radiation and they'll do surgery on these children. And hopefully, when we get it, there'll be no metastasis. Because again, if there's metastasis, it's going to be harder to take care of. And that's Ewing sarcoma. And I mentioned it earlier, symptoms that you see, bones, juvenile idiopathic arthritis. I used to always call it JRA. Well, I can't anymore. It's JIA, because again, they changed this name too. Usually you'll see these children between 1 to 3 years old when they first start. And again, this is the child who maybe is, stiff in the morning, limp in the morning, or maybe you see swelling hands or eyes, or, not eyes, hands, or ankles, wrists. You'll just see something. So that morning stiffness, and it's hard to walk in the morning, and they'll be limping. Again, joint disfiguration, you'll see, and it's not every joint, it's here or there, it's where it wants to be. And then these children can get something called uveitis. There are joints everywhere. And in the eyes, it's something called uveitis. They need to go to eye doctors once a year, minimum, to be checked, okay? I mean, I told you the weirdest thing I've ever seen, and of course it's me, is there's a joint in my voice box. And that voice box, it's swollen when, my arthritis is not under control. And that's what this is. And this is all part of why I have a squeaky voice. It's not sick. It is my not juvenile, but just regular rheumatoid arthritis. Gee, juvenile. I'm a kid again. All right, how do we diagnose it? Well, see, this is the issue. There's no definitive test. There's all things you can look at, and you try to put the picture together, but who knows, is it really good? I mean, for instance, it took almost 10 years to diagnose me, because of course, every weird thing or every weird elevation, that's the one I had. I didn't have the normal stuff that went on. But usually you see any of the inflammatory factors will be elevated. Your SED rate, another one is something called a CRP, a C-reactive protein.
We use it a lot in the premature infants looking for infections. It would be elevated. ANA would be positive. Rheumatoid factors would be positive. When you're having a flare, your white counts or leukocytosis should be elevated. But, they're all different for everybody. Now, there's no cure. There is goals of treatment, of course, is to try to decrease the pain and preserve function of, your body and all the joints. And of course, trying to relieve those symptoms. I mean, the biggest symptoms is pain because it hurts when it's flared and you're trying to walk and your muscles don't want to move. It hurts. Basic pain medicine is NSAIDs, just simple ibuprofen or naproxen. Those are two things that are generally prescribed for it. In flares, they'll give corticosteroids, but how much corticosteroids can you give? So remember, there's side effects from that. And then we do have those anti-rheumatic drugs, Humira, Enbrel. You have infusions that you can give. I think the biggest one that we hear of that's been around forever is Remicade. And all of these things can be given to kids too. It's not just adults, it's also children. And then most every person who has rheumatoid arthritis will be getting some sort of form of methotrexate, whether it's sub-Q or whether it's pills by mouth. How do we take care of it? Well, we need to move. We need physical therapy. Honestly, I go in my pool and I'm back in my pool again as of yesterday. So I am more than thrilled. Walking hurts. The joints hurt in my ankles, my knees, my hips, my toes. But in a pool, I can be a fish and I can move and it gets all of those joints moving. Whatever works for that child, as long as they're moving, is good. Another thing is sometimes when you're having a flare, my left knee gives me a lot of trouble. So the doctor's like, well, put heat on it. Well, don't put heat on anything on me because it makes it worse. I like ice. So whether it's ice, whether it's heat, use it and then trying to keep it moving. I mean, this child goes through a lot every morning. So, and the family has to listen. And my poor husband, yeah, my knee hurts today, or hear me going, ooh, as I get up. You know, those noises you make. It's just part of the beast. This is what happens. So rheumatoid arthritis affects joints. The body attacks it. It's an autoimmune disease. Lupus or systemic lupus erythematosus is another autoimmune disease where the body says to the organs, let me come get you. So it starts attacking the organs. Now, lupus is more common in girls and women. So they are just over being school age into teenage. You see more in the African American, Asian, Hispanic populations. We don't know why. We know that there is some sort of familiar tendency to it, and we know triggers. Well, any autoimmune disease is going to be affected by hormones, drugs, infections. Stress is a huge one. But lupus, one of them is exposure to sunlight. So decreasing the exposure using, sunscreens and limiting the time is very important. One of the things you see with lupus is that butterfly rash. And you could see, it could look like this little girl with just pink cheeks, or it could be that. The rashes all are different, okay? They usually start to appear nausea, vomiting, diarrhea. And again, they have pain, somewhat like rheumatoid arthritis feels. They get stiff, but this one, the joints don't get deformed, okay? But they start with that forgetfulness and then they go neuro, which is seizures. And then of course it could be paralysis. It affects the heart. So you see pleurisy, pericarditis, affects the kidneys. You'll see failure or you'll see the beginnings of protein in the urine. So goals of treatment, there's all different ways to treat it. Many of them are getting low dose prednisone every day with other medications like Plaquenil, but they're all different, depending on the child, symptoms, the doctor, etc. But what we need to do is, again, decrease the sun. We know it's the flares, try to decrease those stress, and trying to keep these kids from having these flares. So let's give you this question. Kristen's a 10-year-old, sustained a fracture in the epiphyseal plate in her right tibia when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What do we know about an epiphyseal plate?
It's B.
It's all about the growth plate, right? So bone growth can be affected. Yes, very good. Okay, neuromuscular, musculoskeletal, muscular dystrophy, right? So cerebral palsy, you think muscular dystrophy, you think cerebral palsy. It's basically a group of permanent disorders of the development of movements and postures, okay? Because they can't control the way their body moves, it limits their activities. It's abnormal muscle tone. It is the most common permanent physical disability, and most children, one of the things they have with it, 15 to 60%, because cerebral palsy nerves has to do, they have epilepsy. Now, what causes cerebral palsy? Well, it could be something in the brain. It could be some sort of lack of oxygen to a piece of the brain, as in a vascular occlusion. Could be some sort of degeneration that's gone in there. Low birth weight. If you're born at a low birth weight, you have a problem with nutrition. You have a problem maybe at birth. You had a hypoxic, anoxic episode, or during the growth, they have areas where they do have these septic spells where they can be anoxic, hypoxic, or intubating them. They had those areas. A lot has to do with oxygen, is what I'm trying to tell you. The hypoxic infarct or hemorrhage. I mean, I've seen children that are normal up to the point of delivery, and at delivery, they are full and the head's hanging out of the vagina trying to come, but it doesn't fit no matter what they do. They have to do an emergency C-section, push it back in and get it out. Sometimes then I have seen those hypoxic episodes where they've had some degree of cerebral palsy. So how do you evaluate it? Well, any child who has been premature or had any hypoxic or low APGAR scores at birth are going to be monitored very closely. There is different sort of cerebral palsy. The one that we think about when we think of cerebral palsy is the one that is the spastic cerebral palsy. This is the one who can't sit without being strapped into their wheelchair, or they can't walk, or they're just really tight muscles and they can't control them in their mouths and their arms is part of it, okay? So we do, number one, the physical exam. We go to that, CAT scans, et cetera, looking for that. And of course, we're going to see, was there any metabolic or genetic reason for this to occur? What do you see with these kids? Well, fine and gross motor development absolutely is going to be delayed. My little Jonathan is my favorite little boy, where I did clinicals at a special needs daycare and did clinicals for Cutler Bay. Little Jonathan, cerebral palsy. When I was there, it's been like 3 years since I've been there. I missed the kid. He was spastic cerebral palsy. He was averbile. He didn't speak. He couldn't even eat by his mouth. but his brain was there. And he would look and he would see me, and the smile would go ear to ear, but his hands would come up and he'd start having a spasming. I mean, he just was so excited I was there because he knew I was going to go give him a hug and a big kiss. He just knew it was happening. You know, these children are so alert, and because they don't talk, they're nonverbal, because they don't eat right, they're in a wheelchair, they have this spasming posturing, you don't think that their brains are here. Well, I hate to differ with you, but they absolutely are aware of their surroundings. It's the difficulty on how do I tell everybody I know what's going on. So what is our goal with cerebral palsy? Well, I just mentioned one of the most important, communication. Now, little Jonathan had a little pad, and it was given to him by the March of Dimes. They're like $10,000 or more for these things. And he was able to speak through this pad, you know, and it was really precious that I could communicate with him. He was even educated with this pad. You know, years ago, when I first started into these types of children, I worked as a lifeguard, junior, senior lifeguard, and water safety aide. And at the YMCA, I used to teach children with some sort of cognitive delays how to swim. And one of the most wonderful things I've ever done. And when I was talking with them back then, you know, these children, I mean, the younger kids, we taught them how to swim, but children that were in the home, literally, they fed them, they bathed them, they got them out of bed, they put them in front of the TV. They weren't educated like they are today. I mean, Jonathan went to school. He was learning shapes. He was learning colors. I mean, this is something we didn't do. We didn't realize that these children do have a capability of learning. So today we are doing that. So I've seen an incredible change, turnaround in the years I've been working with these kids. Probably one of the reasons why I like PED so much. So getting them moving around, locomotion, you know, these children, like this little boy here, he looks like he has cerebral palsy because he has the braces on his legs, but he's got a bike, he can walk around, he can move around. Ever go to a pediatric hospital and you'll see children in motorized wheelchair going beep, beep, or they have a horn on their chairs and they're just, you know, fast going up maybe to the cafeteria to get something. Locomotion, it gives them such a peace of mind to be able to move around. You know, we many times do have to adapt a lot of things to the child, but what we do, it's to help them be able to move around, to communicate, to do things for themselves, and to be around other children. You know, maybe one thing that Jonathan did around other children, he couldn't speak, but what if there's a video on that's talking about clapping the hands? And he would try to clap his hands. I mean, he wouldn't always hit his hands, but he was trying really hard, you know, and that was part of his socialization. We use ankle foot braces because we don't want to have that foot drop because of those spasming muscles. Those real spastic deformities, they will do those tendinotomies, they'll release them to open it up. You know, Jonathan did get botulism and it did help. Another thing they gave him is what they use for Parkinson's, that carbidopa, levodopa. It's used to help relax muscles. They're using that now on children with cerebral palsy, and it did release some of those spasms. And remember, a lot of these kids do have epilepsy. So a lot of them are on those medications, which causes those, you know, hyperplasia, thickened gums, right? And acne. So those teeth, you've got to be really careful with them because they will, because of all of the extra gums, etc., they can get really bad dental cavities. So great dental hygiene is important. And of course, physical, speech, and occupational therapy are all great. You know, we can do a lot for these kids. And once they reach a goal, get them a new goal. I mean, Jonathan has far gone beyond what anybody thought he would do. You know, their cognitive impairment, yeah, he does, but he's got a lot more than they thought. They're not going to grow as well as they should, you know. He may not talk as well as he should. He doesn't eat by the mouth, but all of these things, he can live a pretty long life. Just remember, we have to have that family be able to take care of this child once the family's no longer there. So we need papers written up for that child. So care management, besides again planning for the future, always make sure the kid at home has the medications, family knows how to do it, the diet, they know how to deliver it, the equipment at home that he needs to take care of him, that he gets all the therapies he needs. Safety is always very important. These kids are spastic, and just being in bed, you know, they get so spastic without even knowing it, they can roll off a bed and, you know, break bones, and we don't want that. And again, this child takes a lot of care, so support that family. Now, GIGU, we talked about a gastroschisis and we talked about a bladder exstrophy, right? That's in the front of the body. Well, sometimes the meninges and spinal cord in the lumbar area of the spine, that doesn't close. So those meninges and spinal cords are like pulled up and out. So they're stretched up. With that stretching, remember, those nerves that attach to that meninges and spinal cord control the lower abdomen, the bowels, and the urine function, okay? Just so remember those things. So this is called a myelomeningocele, and it causes what we call spinal bifida, basically. So literally, there's going to be decreased or no movement in the lower extremities. It can do to many different things. It's usually mom is obese or diabetes or low B12. And it just is a neurotube deficit, as we call it. Remember in pharmacology, you're taught about folic acid to be given 1 month before you want to get pregnant. Well, this is the neurotube deficit that they were talking about, is this. So I just put two pieces of the puzzle together for you. So how do you manage it? Well, after the child is born, they cannot lay on their backs because their spinal column and meninges is hanging out. Number one is decrease infection. I mean, that's your spinal column there. So again, having something over that to protect it until we have to the point where we can put it back inside the body. Now, a lot of times, because those meninges and spinal cord has been stretched so much, nerves that broke that go down to the feet and legs. So they can't move their legs. They're paralyzed, literally, from that point down. What other nerves are control what at that level? It's also your bladder. So they may not even know they have to urinate. So this child might have to be catheterized every 4 hours for urine. Another thing is the bowels, making sure that the bowels are moving. Again, do they have the nerves to push the stools out? So these are two things we watch out for. And that decrease in movement, you know, we've got to make sure that we are exercising those lower extremities too. You know, these children can be perfectly normal. Of course, I have a story about Manuel Louis. We had 3 rooms in the newborn ICU, and each room held about 10 to 12 kids. And it was right after a change of shift report, and I'm in the room, and the other nurses had gone to get whatever they wanted to get. And I was in the room, and next to a child, Manuel Louis, was the mother sitting there crying. And it was not my child. It wasn't my baby for the night. But I'm not going to leave a mother sitting there crying, am I? That's just not me. So I went up and I'm like, Mom, what's the matter? And they go, they don't. And I saw what, you know, it definitely, we had a myelomeningocele, so I knew what was going to go on. I've seen quite a few of them. And I said, so what's the matter, Mom? And she goes, you know, the doctor says he may not make it. And I looked at her and I said, you know, Mom, your child is beautiful and we're going to make it. And he's going to get through this. And I said, and you look like a mom who'll do everything you need to do to give him the best life you possibly can. I said, okay, I want you to sit down right there in that chair. And what I did was I got a diaper on him and I got a blanket on him. I picked him up and I put it in her arms and I said, now love your baby. Isn't he gorgeous? And he had a full set of hair and he had these cute little cheeks. And she just sat there and cried and rocked and, you know, was so happy. Well, the kid went home, etc. All right, fast forward 13 years later. 13 years later, I'm in the emergency room. And through this glass door, I saw this mother pointing to me. So one of the clerks came out and says, Betty, this mother says she knows you. And I went over and I said, may I help you? And I saw this kid sitting in a wheelchair. And I looked, I said, are you Manuel Louis? How do I remember these names? I have no idea what my car keys are. So he goes, yes. He says, Betty, oh, they called me Boop, okay? I was always called Betty Boop because they would remember my name because Boop, Boop, Boopy Doop, of course you're gonna remember it. I'll always be remembered by that name. I want you to know what you did for me that first night has sung in my heart for the last 14 years. My child just went to his 8th grade prom. He's in normal school. He's a great kid, and I want to thank you. Then she pulled out, this was just mind-boggling, this little key chain with a little plastic thing about, 3 by 4, and a picture of me holding Manuel Louis when he was an infant. And she just wanted to hug and thank me. She said, I've been looking for you forever. And I just saw you and I just had to come and hug you. So you think that you don't make a difference. Do you see how just taking a moment, helping a mother for a second made a lifelong impact? And that's my Manuel Louis. There's what I just said about the folic acid, just to take it. All right, let's go on a couple different spinal dystrophies. Werdig-Hoffman is basically called a floppy infant. These children are born and you notice almost instantly they're not doing anything and they just are floppy. You pick them up by the arms, their legs, their head goes back, there's no muscles. And because of the muscles, the floppy, their diaphragm's the muscle, they usually die about 2 years old. You see it at 2 months and there I'm saying it's pretty quick, it's pretty sad. Duchenne muscular dystrophy is the diagnosis Hesses and Kleck's love to talk about. That's your hint. Duchenne muscular dystrophy is X-linked, so mommy gives this to the baby. And it is a child with muscular dystrophies. It's usually males. You usually start seeing them diagnosed about 3 to 7 years old. These children will have these big hypertrophic calf muscles. They sometimes walk even on their toes. And they are going to get weaker and weaker and weaker, okay? These children usually get obese. They're cognitively delayed. And because, again, you're looking at muscles, your heart's a muscle, and your lungs, the diaphragm, they usually die, around that teenage thing. Now, they can live, a little bit of their life, but it does need care, and it also needs that diagnosis, like, what am I? So when we see this muscles, usually it's the hypertrophic muscles that are like that clue. Something's going on with the muscles. Let's do something called an electromyography or an EMG. I had it done once for a cervical spine injury many years ago. And they attach these little probes on you. There are some of them that do like little acupuncture needles, but usually it is just those little tabs like EKGs. And they put a little electricity in it and they watch the muscle spasm. Now, it hurts. And it does. And there's going to be muscle hurt for, a day, once they get back to the room. Let the mother know it's normal and it will go away, to give them some Tylenol, Motrin or something when they come back. Absolutely. Other signs and symptoms is they're going to waddle. Remember, when you don't walk, your muscles are weak. You're sort of very hesitantly going to like waddle back and forth, okay? And because their muscles are weak, they're going to be falling. And does anybody know Gower sign? It's something I do every time I get off the floor. I walk up my legs. It's like I walk up my legs to be able to get my body caught up. I mean, it's just the way that I do it. They also have that thing called lordosis. That's the lumbar spine, lumbar lordosis. It is that curvature. Again, those enlarged muscles. And again, that mental impairment. And because their movement, they are going to be a little overweight. Treatment is exercise, keeping them moving, keeping those muscles going as long as they can. Again, genetic counseling is needed in case mom wants another child, it's coming from her. A decision will have to be made. Do they want it? But it's just treatment for what you see. If if the problem is with, the physical therapy, we'll just, be doing those and the exercises. Sometimes they get contractures doing surgery. Guillain-Barré. Have you studied that one in MedSurg 2 yet? Guillain-Barré is something that happens called infectious polyneuritis. So some infection has attacked nerves. Usually there's an upper respiratory infection like a month or so before this condition. It is less often than adults, but children can get it between the ages of 4 to 10. And what happens is the feet start to feel numb, as in you're placing them on the floor and you don't feel like they got where they should get. They don't feel it. And it starts at the feet and it works up, or what we call ascending paralysis. Ascending goes from the floor, from the feet, and goes upwards. So this is going to start with falling, tripping, that waddling, stumbling, and then it's going to get to the point where maybe it gets to that bladder nerve and you have incontinence or constipation. Remember, nerves in that area, urine or bladder. And then it gets up to the point where it hits the phrenic nerve. Once it hits the phrenic nerve, this child stops breathing. There's no nerve. It doesn't stimulate the diaphragm. Again, respiratory collapse, nothing. So if you have a child with diagnosed Guillain-Barré, one of the things you'll be watching is the O2 saturations and their respiratory status, right? So these children, what do? How do we treat it? We treat it maybe steroids, but IVIG and plasmapheresis, try to clean up the blood from that viral infection they had there. Again, if they need to be, these children end up intubated. If it's a long-term intubation, they'll have a tracheostomy. And our goal is to prevent complications, which are they're paralyzed. They are totally awake and alert, but they can't breathe, they can't move. It is scary, okay? Very scary. These children, we need to make sure that they don't get blood clots and we keep their lungs from getting atelectasis in there. Once we start seeing, now what happens is we have them on a ventilator on a set rate of respirations. All of a sudden, one day, you'll see the child take a breath over the amount of respirations that the ventilator set for. And you usually can hear that. Now we know it's going to go starting to recover, which means now the lungs are going to start to breathe, the nerves in the intestines and the bladder starts to come around, the nerves and the legs start coming around, and then all of the paralysis is gone, okay? Long-term recovery on those children, but it is due to a viral infection. And our big thing is watching their respiratory status. Tetanus, lockjaw. This is something where you stepped on a nail, right? So we're going to do what? We're going to be giving, we're going to clean the wound. Usually children step on it. I have actually seen children like even be bit by things, you know, and then walk around. So again, these children, you're going to see a wound that needs to be taken care of. You know, if we're at home, these children just wash soap and water at first. And if they don't have a tetanus shot up to date, they need to go and get one. Remember, tetanus shots are good for 10 years, but if they have some sort of puncture that would look like that, they would give them a booster just to be safe. Now, tetanus affects everything to do with their upper airway, the jaw, the facial muscles, neck, jaw, and it gets in the big spasming and swelling. And when that happens, it is hard to swallow. You go into laryngospasm, and it's just a whole respiratory type of thing that goes on. With all of that swelling and all of that going on, they're going to have rubbing of the tissue, which makes more secretions in there. So it can cause atelectasis, pneumonia, of course, respiratory arrest. Again, these children, they can't breathe. They're extremely alert, but they're, you know, I can't breathe, and they really get anxious. With being anxious, what do you see? You know, their heart rate goes up, they become diaphoretic, etc. Now, usually, if we can give them the tetanus toxoid vaccine, we monitor their respiratory status, you know, these children can do okay. So as I said, clean the wounds even when they're intubated, because, you know, they ended up to the point where their whole respiratory status had gone downhill. Remember, that wound still needs to be cleaned, and they will get the tetanus toxoid or antitoxin, which will help. Again, they are, you know, in bed, they can't move. These children will need to be looked at for their fluid balance, electrolytes, very important, cleaning that wound, and they'll be given that immunoglobulin to try to fight or neutralize those toxins. If those spasmings in those muscles are so bad, so severe and painful, they'll put them on a muscle relaxant. You know, this would be a paralytic agent that you would use like to go to surgery, right? Which just completely, everything is completely paralyzed. Pavulon is a big one that they use for this until we can get these kids doing better. If they're okay after 3 to 4 days, usually they'll be okay. If not, they usually will not make it. That's how severe it is. Now, botulism is food poisoning caused by Colostrum botulism. Now, botulism usually is given in children. It gives to children with honey. No, in many households, we have a jar of honey or this called Caro syrup. There's light and there's dark, right? Grandma's going to say, okay, your kid's constipated, give them a little honey, give them a little Caro syrup. In some cultures, this is what I've heard. Problem is, was that honey Caro syrup, was it sterilized properly? Was it stored properly? How old is it? And how old was it before you even got it from the store? So never, ever give honey or Caro syrup to infants less than 1 year old, okay? I wouldn't give it to them till they're over 2 years old. It's just a very dangerous thing. What you see with honey is about 12 to 36 hours after they get it, all of a sudden, they're going to start vomiting, dizzy, headaches. They're going to see double vision. And again, it's all upper airway and what we call respiratory or life-threatening respiratory paralysis. So how do we treat this one? It's again, it's the immunoglobulin. It's the botulism immunoglobulin. Again, it's going to take several days for this to clear up. And again, these are little kids. So you always are concerned about nutritional support, even for a couple days in the ICU because of, botulism or tetanus. You still maintain nutrition. They need it for growth. They need it for cognition and for the body to be healthy. And again, because it does affect the respiratory system, support the respiratory system the way that it needs to be. Now, spinal column injuries, motor vehicle, I've already told you those. Sports, yes. Think about being born. We pull the head out of the vagina, right? Could that affect the spinal cord? I've always wondered that. Yes, it could. Any sort of trauma. And then something called hyperflexion, hyperextension. You get hit by the back in a car, your head goes forward and backwards. So you have those injuries there. Now, let me tell you a spinal cord injury that I was the primary trauma nurse on, which means I'm in charge of the kid and everything that went on. 16-year-old boy came in through a helicopter, trauma helicopter, by the city. And the kid was playing baseball on a Saturday afternoon, and he slid into third base, and his head hit the knee, and the whole crowd heard a crack. Instantly, his right leg went numb. Somebody at the scene knew to not move. They called 911. They came in, they airported it, got it to me. What is my job? Well, they're already telling me he already has some numbness in the right leg, all right? So he comes to me, he's got the big collar on, he is taped to a backboard, and I've got to give care, and everybody's wanting to take care of him right now. So, number one, I told the kid who I was, that I was there, I was his nurse, I was going, any questions, told him what was going to be happening really, really quick. I asked him, I said, so tell me about what you're feeling. Can you feel your right leg? Not much. Can you feel your left leg? I don't feel that. Yeah, okay, I can feel there. So half the left leg was going too. Neurosurgery came down, neurology came down. My goal during all of this is to keep that neck immobile and don't let anybody touch and turn him, because any movements could sever that spinal cord completely. Sent him, they did an MRI on a Saturday from the emergency room. They don't do that. But this kid had an angulated, I'm talking, it was an angle, C5, C6 fracture of the spinal cord. And they did the MRI to see exactly what was going on. I had to get the kid from the board, from the stretcher, onto the MRI table. And I made sure it was only on my count, and I took the head. It's my head. Did the MRI, came back. I kept talking with the kid. We got him up to the ICU. We put tongs in him, right? And we put him in bed facing opposite. So his head was on the foot of the bed, and we had that traction and weights coming over. Put him on a cooling blanket. And of course, we gave him sedation for that. He went to the OR the next day. One of the most mind-tenseful situations. I went to see him 2 weeks later up in his room. He had a surgery. I heard he did okay. All of the movement came back. He had slight numbness in his right leg, and he was going to rehab the following day. And he gave me the biggest hug and told me, thank you. I mean, this kid, the reason why he is not paralyzed today is because I didn't let anybody touch him unless it was under my count, my supervision, and that neck I was supporting, because your job is just the immobilization. don't let that neck move, because he could have been a paralyzed child and it wasn't going to be on my watch. So priority, proper immobilization, okay? And to keep that kid straight and not let anybody move it. Again, after that, it's going to be the surgery and follow up and normal surgical outcomes. So question, a progressive infantile spinal muscular dystrophy, the most common paralytic form of floppy infant. Do you remember the name?
C.
Yes, it is. Good job. All right, lots of stories today, huh? So who wants to win the Kahoot today? Della wants to win. I know that. Katasha's going to win. I know. Shelly, I see you. Kayla's there. All right, let's do it. There's like, I think 36 today. It wasn't too crazy with the amount. And we should be out right when we should be out today. So that's a good thing. And can you imagine no quiz today? What are we going to do? All right, let's get going. Week 9, 2 more weeks and HESI. Wow. A multi-select. What is the priority for the nurse to assess following a cast application? We want to watch all the P's, right? Pulses, pain, movement, sensation, all of those things, very important. And we need to tell our child and our parents what to look. What should the nurse monitor after a soft tissue injury? This could be just a little bruise, right? Again, remember that ecchymotic area could have a lot of deep tissue injury. So neurovascular signs, is there blood flowing there? Want to be sure. A fracture that penetrates the skin is called. That means this bone is sticking out there. And if we don't take care of that, we're going to have an osteomyelitis, right? It's called an open or compound fracture. Remember, the priority thing that we do for these children is IV antibiotics, preventing infection. What is the priority nursing care of a child with a compound fracture? I mean, it could be just a finger, just a finger, just a toe. It's no big deal, right? Again, priority is IV antibiotics. I mean, I know that students generally want to say, well, if you have an open or compound fracture, I want to give pain medicine. Well, yeah, you do, but priority is to prevent infection. You prevent infection, you're going to decrease the length of time the child has pain, okay? Because if you don't treat it, the pain's going to get worse and worse and worser. What is priority nursing care for a child who fell off the second floor balcony? And actually, I had a little girl, 2 years old. She got somehow through the spigots and she went down. Again, remember, this child has come to you usually through some sort of rescue, and they usually do have on, neck braces and their backboards, etc. Make sure we keep that spine immobilized and that we don't let anybody mess with it. That is, unless the doctor says to take this neck brace or something off, make sure we keep that immobilized. You do not want to have a child having paralysis because you didn't do that. Principles of managing soft tissue injury include what? It's all about RICE, right? Rest, ice, compress, and elevate. And if we can prevent it, that'd be good. But rest, ice, compression, elevate. Epiphyseal plate fractures in children may do what? So epiphyseal plate fractures is all about the place where the bones grow. So you don't want the bones to be crooked, etc. So you don't want to disrupt the growth. Very good. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? It doesn't matter if it's skeletal. You can have a Steinman pin in for a fractured femur, or you can have Buck's traction, which is a skin traction. So either or does the same thing. So when you are taking care of any sort of broken bone, whether they're in traction, in a cast, anything, an absent peripheral pulse means there's no blood flow. That is an emergency. Tell the doctor now. A multi. How should the nurse care for a skeletal traction for a child with a fractured femur? When you look at that picture, look at those sharp edges that are there. Can you imagine that going into the muscles and nerves and the amount of pain that child would be in? It's quite a bit. So you have a child that's either on the skeletal traction, which would be a Steinman pin, or skin traction, which is Buck's traction. You need to document what is the weights that are on there. You also need to have those weights freely hanging, that there's no restriction. You must have constant pull there. They are on 24 hours a day. They are never taken off. And you're also going to be monitoring those neurovascular signs too. Those toes, they're pink, they're warm, they're good capillary refill. Very important. When caring for a 9-year-old Buck's traction, what action by the nurse is correct? Just checking those capillary refills. You're not going to have anybody sitting on the bed. You're not going to raise or lower the bed. You're not going to have the head of the bed way too high either. You don't want to decrease the pull on it. And of course, those weights must be free hanging 24 hours a day. Another multi. Which assessment indicates an infant has developmental dysplasia of the hip? A Moro reflex is your startle reflex. It has nothing to do with hips. Positive ortolani, those asymmetrical leg folds. Those positive Babinski has nothing to do with developmental hip dysplasia. It just shows you that their foot has the nerves that are in there, which really you don't need to know. Just do they have pulses down there? What position do you put the legs of an infant with hip dysplasia? Oh, I spelled that wrong. It has to be an abduction. Think baby, baby. Abduction is where the hips go. What statement by parents indicate more teaching regarding their 2-year-old with club feet? Their infant has club feet. What statement indicates more teaching is needed? So if they're telling you that it's 1 month for a new cast, it's every week. Remember, 2 to 3 weeks. We know that's all they need for a broken bone. Every week they need serial, the Ponseti method, so they can straighten out those feet. Again, it needs to start quickly, right away, while you have those soft bones. And they do need follow-up care until they're grown to make sure that their feet are staying the right way. And usually they're going to give you, as I said, shoes that are better to put on their feet. Another multi. Osteogenesis imperfecta. Osteogenesis imperfecta is all about everything is crooked, they've been broken. It's called brittle bone disease, basically, and there's no cure for it. It doesn't matter meds you give, there's still going to be very brittle bones for life. What is the pathologic cause of leg calf Perth disease? So it is an ischemic aseptic necrosis of the femoral head. For whatever reason, there's not an infection, but they don't get enough blood supply there. So the femoral head dies. We treat it how? NSAIDs, bed rest, maybe bucks traction, and a good healthy diet, good protein. Kyphosis. And that's humpback. That's a thoracic spine is humpback. Lordosis is described as and that's the inward curvature of the lumbar spine. You see this here with Duchenne muscular dystrophy also, lordosis. Scoliosis. Remember, S-shaped. Scoliosis is the S-shaped. Adolescents with scoliosis have up to a 45% curvature of the spine, would need to do what? How do you treat scoliosis up to 45? So I say, give me 40, 45, books are a little bit different. So when it's to that point, it's just wearing that brace 23 hours a day. The other hour is for showering and putting on a new t-shirt and cleaning the inside of that brace because you're sweating within it also. And that with physical therapy strengthens the muscles and straightens up the back. What is osteomyelitis? Osteomyelitis, itis is an infection, and osteo, bone. So it is an infection of the bone. And how do we treat it? IV antibiotics, bed rest if we need to. Goals for juvenile idiopathic arthritis include JIA. So if you have a problem with your joints, you want to reduce the joint pain and the swelling. Very good. Another multi. What might you anticipate for a child diagnosed with JIA? So it's all about the joints. So stiffness in the morning, difficulty walking, that uveitis. Remember, the facial rash is lupus. It's not JIA, okay? So the eyes, the redness, joints, difficulty walking. Another multi. What can help a child with lupus erythematosus prevent exacerbations? How do you prevent flares? What's one of the ones I think is very a good one for me living in South Florida to know this? So we need to wear sunscreen, decrease exposure. And the other thing we do is prophylactic antibiotics or steroids or both before like dental extractions or for little mini procedures. Yes. What organs can lupus affect? All of them, doesn't matter. Organs, period. What is cerebral palsy? It's all about body movements and muscle coordination and the inability for you to control those sort of things. Affects gross motor, fine motor development also. A myelomeningocele. What is that? We've talked about gastroschisis, we've talked about bladder exstrophy, and now we have this one, born on the outside, not on the inside. And all of them are a little different in the management of care. But myelomeningocele is when spinal cord and meninges are born on the outside. Again, at birth, our priority is to keep that from being infected. These children will lay on their bellies. This is the one time we do, and they have to be on a minimum of an O2 sat monitor to watch their breathing. Infants with myelomeningocele demonstrate what? Just think myelomeningocele. Well, what is it? It's the meninges and the nerves and the spinal cord are stretched out, and on the outside of the body, it's been stretched. So you're going to have motor and sensory impairments, or one or the other, but usually it is both. Monomeningeals have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? So again, when you're talking about sensation, we're worried about the bladder. I've seen some children, you can just push on it when they're infants and it will urinate without being catheterized. But many of these kids, as they get older, require every 4-hour catheterizations. As they get older, a lot of them are taught how to do it themselves. But urinary retention, because they have no nerves, they don't feel it. Their bladders are full, they don't feel it. And again, remember to monitor their bowels, because again, they don't have that nerve there. You don't feel it and they can't push it out. A key feature of Duchenne muscular dystrophy is what does the word say? Muscular dystrophy. Some sort of dysfunction of a muscle. It's progressive muscle wastage. Again, they love Duchenne muscular dystrophy. Every student ever sends me a message after their NCLEX, they say, yep, Duchenne was there, and so was tetralogy of Fallot. What is one of the procedures that a child with possible Duchenne's may need to diagnose this prescription, this condition? Like, what is that test, that procedure that is done? And it's that electromyography, or the EMG. Remember, it's causing muscles to spasm, and it does cause pain afterwards, which will go away. How is Duchenne muscular dystrophy inherited? Where does it come from? So remember, it comes from mom, X-linked recessive. So mom wants to go have, another child, is something that she should be aware of. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, we worry about all of that numbness of the nerves that go from the feet going upwards. We're always worried about respiratory, maintaining an airway. Absolute priority. Yes, they're going to have, numbness in their feet, and they're going to be tripping and falling, and maybe incontinence or constipation. But without an airway, nothing else matters. So worrying about their airway. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? We know it starts with the feet and it works upwards to their lung. What is the term for that? What is that called? It is called ascending. Has nothing to do with the morning, has nothing to do with descending. When they get better, it descends. It's not like juvenile rheumatoid arthritis, worse on awakening. No, it's all about feet upwards, ascending. A multi. Treatment for Guillain-Barré include what? Remember, Guillain-Barré was possibly due to an upper respiratory infection, so viral. Antibiotics, no. But intravenous immunoglobulins, absolutely. Definitely we need respiratory support. And then they say maybe steroids, okay? Heparin, no. What type of cerebral palsy causes hypertonicity and poor fine motor skills? This is my little Jonathan. And it's called spastic cerebral palsy. It's what you think of, that little, hypertonicity, and they have no control of their muscles. And all I can see is this big smile still smiling at me. What priority action should a nurse take to a patient with suspected spinal cord injury? Working in the ER, I've seen a lot of different things, but that little 16-year-old boy was all about immobilization of the spine and making sure I protected that he didn't get paralyzed, because those spinal columns are really, really fragile. Yes, watch that spine. You should get a tetanus shot every blank years. We know if there's an injury that's bad, the doctor's going to give a booster, but generally, we should have it every 10 years. When I first started in nursing and knowing, I think it was every 3 years. Then they went every 5 years. Now they're every 10 years with boosters if you need it. What is the symptom of tetanus? Stepping on that rusty nail, right? Remember, we got to make sure that we keep it clean, wash it soap and water. That's priority when we first get it. And then giving those tetanus toxoids in order to prevent that lockjaw, because it goes all the swelling, respiratory distress. Those kids are extremely ill, and not all of these children make it. That's how serious. Most common causes of spinal cord injuries are what? Your last question. It has to do with cars, always, motor vehicles, driving, sports. Those are the most common of all. Very good. So number 3, Danny. Good job, Danny. Number 2, Lisa. Good job, Lisa. Number 1, Della. Good job, Della. Number 4, Jazz and Mia. Good job. Okay, next week you do have exam number 3. Remember, try to hit one of the live reviews. I think listening to live, you sit there, you can ask questions when you don't understand something. So go if you can. Again, mine will be on Thursday at 2:00, and you have them posted in your announcements to get there. We will be doing a HESI review as your class after the exam next week. So I'm giving you your first one, and then I'll be doing a question answer type thing on Sunday afternoon before week 11 in your HESIs. It is a great tool. I used it last semester. It was the first time, and the students loved it. That I'll just say, okay, respiratory, what do we know? What do you look for? General, and then make you start thinking a little bit more about all the things you need to know, okay? Any questions from anybody about anything? Remember, if you didn't get your pediatric assessments in, you need to get it in before Sunday. It is a minus 10%. And I'm only giving you one chance to make changes, but I'm still giving you one chance after I grade it. So be aware of that, all right? I'll be checking the ones that, I've been working with already. This gone back and forth because I want you to get your best grades possible. So just tell me what's going on with your life and I can help you. If I don't hear from you, I don't know. Okay? Nicole, he's adorable. I can give him a hug. I love hugs. Do I get a kiss? Come on. Yeah, you. Oh, a moi. Oh, I like a moi. Good job. Have a good day, everybody. Let me know if you need me or if you want to do one-to-one before the exam. You just let me know. I can help you. Have a good evening, guys.